Assalamu alaikum everyone. So in today's video we will discuss cardiovascular system in physiology section. Most important topics of cardiovascular system are components of vasculature, ECG and cardiac cycle. So let's start with circuitry of cardiovascular system. Cardiac output of left side of heart equals to the right side of heart. Cardiac output from left side of heart is systemic blood flow and from right side is pulmonary blood flow. Now let's have a look at the direction of blood flow on left side and on right side. On left side, blood flows from lungs to left atrium via a pulmonary vein, from left atrium to left ventricle through mitral valve, from left ventricle to aorta through aortic valve, from aorta to systemic arteries and systemic tissues, and from tissues to systemic veins and vena cava, then move on to right side from vena cava to right atrium, and from right atrium to right ventricle through tricuspid valve, and from right ventricle to pulmonary artery through pulmonic valve, and from pulmonary artery to lungs for oxygenation. So we came to know that on left side we have mitral valve and aortic valve, and on right side we have tricuspid valve and pulmonic valve. Move on to next topic. We have components of vasculature. In components of vasculature we have arteries, arterioles, capillaries, venules, veins and aorta. There are different kind of components that we need to know about arteries, and all these components are as follows. We need to know that pressure in the all of these, volume in all of these, resistance in all of these, and blood flow in all of these. So pressure is highest in aorta, high in arteries, low in arterioles and low in capillaries. Volume is stressed in arteries and unstressed in veins. Resistance is highest in arterioles, and capillaries have largest cross-sectional area. I am telling you those points that are important from MCQ's point of view. Arteries are thick-walled and deliver oxygenated blood, and veins are thin-walled and deliver deoxygenated blood. So now we need to know about velocity, blood flow, resistance, capacitance, pressure profile in blood vessels, arterial pressure, venous pressure and atrial pressure. So let's discuss all these components. First we have velocity of blood flow. Formula of velocity of blood flow is V is equals to Q over R. V is equals to velocity, Q is equals to blood flow, and A is equals to cross-sectional area. As we all know that cross-sectional area of capillary is highest, so technically V is equals to Q over R. So V, velocity, is inversely proportional to cross-sectional area, so velocity of capillaries would be lowest. Next we have blood flow, and formula is Q is equals to P over R. Q stands for flow or cardiac output, P stands for pressure gradient, and R stands for resistance or total peripheral resistance. Next component we have is resistance. In resistance we have parallel resistance. When an artery is added in parallel, the total resistance decreases. Then we have series resistance. Largest portion of resistance in this series is contributed by arterioles. Move on to next we have laminar flow and turbulence flow. Laminar flow is straight lined and turbulent flow is not straight lined. Krotokoff sounds are heard in turbulent flow, are caused by turbulent flow. Reynolds number predicts whether blood flow will be laminar or turbulent. Then increased turbulence decreases viscosity and increases velocity. Next, move on to shear. We have a formula that shear is inversely proportional to velocity. Then move on to next component. We have capacitance. Capacitance means distensibility of blood vessels. Distensibility of blood vessels increases in veins and decreases with age. Distensibility means elasticity. So elasticity of veins decreases with age. Next we have pressure. Pressure in aorta is 100 mmHg and in arterioles is 50 mmHg, capillaries 20 mmHg and vena cava 4 mmHg. Move on to our next component. We have arterial pressure, then venous pressure and then atrial pressure. First, let's discuss arterial pressure. Arterial pressure is pulsatile, not consistent during cardiac cycle. That can be an MCQ. Systolic. In systolic, we have highest arterial pressure. Heart contracts in systolic case. In diastolic case, heart relaxes and arterial pressure is lowest in diastolic phase. Then we have pulse pressure. Pulse pressure is stroke volume. Pulse pressure is determinant of stroke volume and stroke volume is determinant of pulse pressure. Its formula is systolic minus diastolic. Decrease in capacitance leads to increase in pulse pressure. So, decreases in capacitance such as those that occur with aging process cause increase in pulse pressure with age. That can be an MCQ. Move on to next. We have mean arterial pressure. Mean arterial pressure formula is diastole plus 1/3 of pulse pressure because greater fraction of cardiac cycle is spent on diastole and this can be your MCQ. Move on to next. We have venous pressure. Venous pressure have high capacitance and can hold large volumes of blood at low pressure. So you must need to know about relation between velocity, cross-sectional area, relationship between volume, pressure, because MCQs will be according to that. Next we have atrial pressure. In atrial pressure is lower than venous pressure. Left atrial pressure is estimated by pulmonary wedge pressure. Capillary pressure is equal to left atrial pressure. So here the components of vasculature ends. Next we have Ecg Electrocardiogram. That is one of the most important topic. So in electrocardiogram you need to know about P wave, PR interval, QRX complex, QT interval, ST segment and T wave. In all of these, most important points are that in P wave represents atrial depolarization. Now that can be your MCQ, that what P wave represents. So P wave represents AD, means atrial depolarization. In PR interval is interval between P and R, that is initial ventricular depolarization. PR interval increases in case parasympathetic system and decreases in case of sympathetic system. AV node, PR increases, AV node action decreases, PR decreases, AV nodal action increases. Move on to next. We have QRS complex that represents depolarization of ventricles. Then we have QT interval. QT interval is the interval from beginning of Q wave to end of T waves. represents entire period of depolarization and repolarization of ventricles. So it's basically both depolarization and repolarization phase. Then next we have ST segment. In ST segment is isoelectric. That can be your MCQ, represents the period of ventricles when they are depolarized. T wave represents ventricular repolarization, and that is an MCQ in your past papers. Move on to next, we have cardiac action potential. In cardiac action potential, we have ventricular action potential, SA node action potential, and AV node action potential. We have different phases. In ventricular action potential, we have phase 0, that denotes upstroke and sodium depolarization. In phase 1, we have initial lead repolarization and sodium decreases. In phase 2, it's a plateau phase where calcium increases and potassium also increases, and they have equal currents. In phase 3 is repolarization phase where calcium decreases, potassium increases, and then leads to hyperpolarization. And phase 4 is the phase of resting membrane potential. Now MCQ can be a type of that, what phase 4 denotes, or which one is the phase of resting membrane potential in ventricular action potential. So it would be like that. Move on to next, you have SA node. In SA node is pacemaker of heart. It has unstable resting potential and it's the fastest phase. It has phase 0, 3 and 4. Phase 1 and 2 are not present. That can be MCQs as well. In phase 0, it's an upstroke phase, and in that inflow of calcium would be increased. In phase 3, there would be repolarization and potassium will increase. In phase 4, there will be slow depolarization and sodium levels will increase. SA node is faster than AV node, and AV node is faster than his Purkinje system. AV node is latent pacemaker, his Purkinje, that increases calcium, slowest conduction. It has slowest conduction velocity. That can be your MCQ, that which action potential node has slowest conduction velocity. So AV node has slowest conduction velocity. Conduction velocity is slowest in AV node, his Purkinje. Excitability, then we have excitability. In excitability, we have absolute refractory period, then we have effective refractory period, and then we have relative refractory period. You can read all of them from BRS for your introduction. That is not much important. Move on to next, we have autonomic effects on heart and conduction velocity. So we have autonomic effects on heart and conduction velocity. For that, we have chronotropic effect and dromotropic effect. Chronotropic effect is related to heart rate. Negative chronotropic effect decreases heart rate and decreases firing rate of SA node, and vice versa. On positive chronotropic effect, dromotropic effect is related to conduction velocity. Negative dromotropic effect decreases conduction velocity through AV node, and positive dromotropic effect increases conduction velocity through AV node, and vice versa. And hence, negative dromotropic effect increase PR interval and positive dromotropic effect decreases PR interval. All these are MCQs that I am discussing with you. So next we have parasympathetic system and sympathetic system. Let's have a look at their effect on heart rate. So in sympathetic nervous system, heart rate increases, conduction velocity on AV node increases, contractility increases, vascular smooth muscle skin constriction, skeletal muscles constriction and relaxation. Heart rate, conduction velocity and contractility were act on receptors of beta 1, and skin and skeletal muscles act on alpha 1, skeletal muscle constriction act on alpha 1, and relaxation act on beta 2. These can be MCQs as well. As in case of parasympathetic nervous system, we have with us heart rate, decrease in heart rate, decrease at muscarinic receptors, decrease in conduction velocity, contractility decreases only in atria. All of these act on muscarinic receptors. Next, move on to cardiac muscles and cardiac output. In cardiac muscles, we have sarcomere, contractile unit of myocardial cells, runs from Z line to Z line. We have intercalated discs, maintain cell to cell cohesion, gap junctions. These are electrical symptom, T tubules that have Z diodes in sarcoplasmic reticulum, storage and release of calcium. That is also an MCQ. That sarcoplasmic reticulum is storage and release house of calcium. Next we have excitation and contraction. Calcium binds to troponin C and activate actin and myosin. There is an MCQ in Rabia Ali that about binding of calcium. We will discuss that later. Then we have contractility. Positive inotropy increases contractility, increases heart rate, increase sympathetic system, increase in glycosides. Negative inotropy decreases contractility, that depends on increase in parasympathetic system and acetylcholine. Next we have Frank-Starling law. According to Frank-Starling law, increase in stroke volume increases cardiac output and increases venous return and diastolic volume. It curves upward, that it increases contractility and increase right atrial pressure. When it curves downward, it decreases contractility, that shows it decreases contractility and decreases right atrial pressure. Then we have ventricular pressure volumes. In ventricular pressure volumes, we have isovolumetric contraction, then ventricular ejection, then isovolumetric relaxation and ventricular filling. In phase 1 to 2 we have isovolumetric contraction. In phase 2 to 3 we have ventricular ejection. In phase 3 to 4 we have isovolumetric relaxation, and in phase 4 to 1 we have ventricular filling. Increases in preload increase stroke volume, increases in afterload decrease stroke volume, increases in contractility increase stroke volume. These relations can be your MCQs as well. Increase blood volume, increase mean systemic filling, shift vascular curve to right. So in further discussion of slope of venous return curve is determined by resistance of arterioles in clockwise rotation. Increase in venous return decreases total peripheral resistance, decreases right atrial pressure, that allows more blood to flow from arteries to veins and back to heart. In counterclockwise rotation, venous return curves indicate an increase in TPR. TPR is increased for a given right atrial pressure. There is decrease in venous return to the heart. Move on to next we have stroke volume, cardiac output, and ejection fraction. So, stroke volume is volume ejected from ventricles on each beat. Now, MCQs can be about stroke volume. Stroke volume formula is end diastolic volume minus systolic volume. That means relaxation minus contraction of heart. Then we have cardiac output. Cardiac output formula is stroke volume into heart rate. Then we have ejection fraction. Ejection fraction, normal ejection fraction is 55%. Its formula is stroke volume over end diastolic volume. That it is related to contractility. Then we have fixed principle. Cardiac output can be measured with fixed principle. Its formula is oxygen consumption over oxygen of pulmonary vein minus oxygen of pulmonary artery. Then we have the most important topic of cardiovascular system, that is cardiac cycle. In cardiac cycle there are different phases. First phase is atrial systole. Events of atrial systole are P wave, A wave, fourth heart sound that is not audible in normal individuals, and there is increase in atrial pressure. Then the other phase is isovolumetric ventricular contraction that indicates increased ventricular pressure greater than atrial valve pressure. Closure responds to first heart sound, and there is also a splitting of first heart sound when mitral valve closes before the tricuspid valve. First heart sound may be split. This is also an MCQ of Rabia Ali. As all valves are closed, so this is the phase of isovolumetric and ventricular volume is constant. Next we have rapid ventricular ejection. In rapid ventricular ejection, ventricular pressure is maximum greater than aortic pressure. Then we have C wave and T wave in it, and bulging of tricuspid valve. Ventricular volume decreases dramatically because of stroke volume is ejected during this phase. Next phase that we have is reduced ventricular ejection. In reduced ventricular ejection, there is decrease in ventricular pressure as well as decrease in aortic pressure. The next phase we have is isovolumetric ventricular relaxation. In isovolumetric ventricular relaxation, second heart sound is audible. It's the end of T wave, and there is also splitting of second heart sound due to delays closure of pulmonic valve. This is also an MCQ. There is a blip in the aortic pressure tracing occurs after closure of aortic valve and is called dicrotic notch or incisura. That can be also your MCQ. The next phase we have is rapid ventricular filling. In rapid ventricular filling, ventricular pressure becomes less than the atrial pressure and the mitral valves opens. Rapid flow of blood from atria into ventricle causes third heart sound, which is normal in children but in adults is associated with a disease. That is also your MCQ. The last phase of cardiac cycle is reduced ventricular filling, diastasis. This is the longest phase of cardiac cycle. This is the most important diagram that you need to know from BRS physiology that explains all the events of cardiac cycle. So reduced ventricular filling, diastasis is the longest phase, as I have told you guys. Ventricular filling continues but at a slower rate. The time required for diastasis in ventricular filling depends on heart rate. For example, increased heart rate causes decreased time available for ventricular filling and vice versa. Next we have regulation of arterial pressure. In that we have baroreceptor reflex. Then we have role of renin-angiotensin, and then we have chemoreceptors. These three are the more important topics in regulation of arterial pressure that I will discuss with you all. Then we have microvascular circulation and lymph that I will discuss later, and summary of control of special circulations, most important topic from MCQ's point of view as well. one of the most important topic. And in the last, we have integrative functions of CVS system, gravity and exercise. So let's discuss it further with the help of diagrams. This is an important table, causes and examples of edema. So here we have table of baroreceptor reflex and renin-angiotensin. These two tables are most important, so read it from BRS Physiology. Next we have summary of control of special circulations. This topic is important for MCQ's point of view. They can ask their percentage. For example, muscle 20%, that can be your MCQ, or your MCQ can be like sympathetic control in muscles, or vasoactive metabolites in muscles, or local metabolites of skin. So that can be your MCQs as well. So read it, must. Then we have few other tables. Summary of response to standing. There is an MCQ in Rabia regarding that. So this is also an important thing. This is a logarithm of standing. This is also a table of exercise. Summary of effects of exercise. Now many MCQs are related to effects of exercise on heart, stroke volume and cardiac output. So must read this table and also the logarithm with that. Then we have cardiovascular response to hemorrhage. Go through it as well, and in the end we have summary of compensatory response to hemorrhage. So this was the cardiovascular system. Now let's discuss UHS MCQ's discussion of cardiovascular system. So in September 17th, 2019, MCQs was determinant of cardiac output. Determinant of cardiac output is venous return. Then there was an MCQ in 2020 February afternoon exam. Sound due to rapid filling and vibration of ventricles is third heart sound. I have told you guys that rapid ventricular filling phase is the phase of third heart sound. I have already discussed. Next MCQ is second heart sound is equals to pulmonary and aortic valve closure. I have discussed with you guys that as in isovolumetric ventricular relaxation, there is a closure of semilunar valves correspond to second heart sound. Then there is an MCQ on P wave on ECG's arterial depolarization that I have already. Then we have cardiac output depends on venous return. That is also a repeat MCQ from September 17th attempt. Then in February morning 2020, there was an MCQ. Sawtooth wave relates to atrial flutter. Then we have November 2019 evening exam question. T wave on ECG shows ventricular repolarization. Next, let's discuss few Rabia MCQs highlights. MCQ number 4 is about cardiac cycle. The note of dicrotic is due to closure of aortic valve. MCQ number 10, S2 splitting is equals to delayed closure of pulmonary valve. MCQ number 14, sound of mitral valve is best heard at left fifth intercostal space in mid-clavicular line. Now this MCQ is from anatomy. MCQ number 17, third heart sound is due to rapid filling of ventricles. MCQ number 18, patient on ECG shows increase PR interval and then a missed beat. Diagnosis is Mobitz type 1. You need to know about Mobitz type 1 and 2. Then MCQ number 20, mean electrical axis of heart is deviated to left if left bundle branch block. Now you need to know about right bundle branch block and left bundle branch block that you will read in pathology of cardiovascular system. Then MCQ number 33, T wave on ECG is ventricular repolarization. Now this MCQ was in your past papers. MCQ number 47, fastest conducting fibers are Purkinje fibers. Next we have MCQ number 48. A man has a pulse rate of 72 minutes per minute. His impulse for this rate is originated in SA node. MCQ number 66. Cardiac output is decreased in standing or sitting from lying position. This is one of the most important MCQ that is repeated again and again in past papers. Then we have MCQ number 70. Cardiac output main determinant is venous return. MCQ number 77. To decrease end diastolic ventricular volume, what should be increased? Heart rate should be increased. MCQ number 218. Giant A wave in cardiac cycle in which of the following? Tricuspid stenosis. MCQ number 268. A patient has ECG which has prolonged PR interval and left axis deviation. What is diagnosis? Trifascicular block. MCQ number 296. Wheatstone bridge principle is used to measure cardiac output. Now that is a kind of different MCQ. Then we have MCQ number 325. Tachycardia will decrease phase of cardiac cycle, ventricular filling. MCQ number 337. Stroke volume is greater in athlete. MCQ number 340. Finding of third degree heart block on ECG represents atrial repolarization. MCQ number 344. What is sympathetic control of vessels greater than local metabolites is equals to skin? Then we have MCQs Errata from Rabia Ali 5th and 6th edition. You can pause this video and mark all your erratas one by one. All other MCQs are correct except these ones, so mark them correct. I hope this video was helpful. Stay tuned for our next video that would be probably on cardiovascular pathology or CNS physiology.